So our topic today is hormone replacement therapy. And despite the fact that menopause can have such a profound effect on the lives and health of women, and that the risks and benefits of HRT have never been more clear, the use of systemic hormone therapy, as Dr. Manson mentioned in one of her articles, has decreased by 80% in the past 20 years. Medical trainees are not adequately educated in the proper use of HRT. I can attest to that. And as she also noted, women's decisions around the use of HRT is now mired in anxiety and confusion. So to clear up that confusion for us tonight is one of the world's most preeminent clinician scientists and a renowned expert in this particular topic, and that's Dr. JoAnn Manson. Dr. Manson is a professor of medicine and the Michael and Lee Bell Professor of Women's Health at Harvard Medical School. She's also a professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. She's chief of the Division of Preventive Medicine at Brigham and Women's Hospital. And she's also there the scientific advisor to their Center for Women's Health and Sex and Gender Medicine. Dr. Manson is a physician epidemiologist and endocrinologist and the PI or co-PI of a range of research studies, quite remarkable actually, including the Women's Health Initiative in the Clinical Center in Boston, the cardiovascular component of the Nurses' Health Study, the vitamin D and omega-3 trial, otherwise known as VITAL, the cocoa supplement and multivitamin outcome study, otherwise known as Cosmos, and the vitamin D for COVID-19 or VIVID trial. Obviously, her primary research interests include randomized clinical prevention trials of nutritional and lifestyle factors related to heart disease, diabetes, and cancer, and the role of endogenous and exogenous estrogens as determinants of chronic disease. Her H-index is 303. And just to put that in perspective, the average H-index of a full professor in the United States is about 12 to 24. An outstanding scientist is around 60, and a truly unique unicorn scientist is around 90. So that just puts in perspective. By the way, I've never met anyone with an H-index of 303 either, not even close. So Dr. Manson, really, thank you very much for taking the time to be with us today. We're all very much looking forward to your presentation and your words of wisdom around this very important topic.
Well, thank you so much, David, for that very, very kind introduction. And as David mentioned, there's so much confusion around hormone therapy. I hope that I can help clarify some of the issues related to estrogen therapy and estrogen plus progesterone therapy. I would like to review for you some of the recent findings from randomized clinical trials and their implications for clinical practice. I have no financial conflicts of interest related to the presentation. Now, as an obscure historical figure once said, things should be as simple as possible, but not any simpler. And I think the epic saga of hormone therapy is really one of the best examples of this. The problem has been trying to make things too simple. A one-size-fits-all answer for all women. Hormone therapy is either good for all women or it's bad for all women. We started out thinking hormone therapy should be given routinely to all women. Before the Women's Health Initiative, it was one of the most commonly prescribed medications. Then after the Women's Health Initiative, as David mentioned, there was a reduction of 80% in the prescriptions for hormone therapy. And clearly, both approaches are not appropriate. Hormone therapy should not be used for all women, and it should not be denied to all women. There are some women who are very good candidates, and it's really important that clinicians understand the research and how to identify the women who are good candidates for hormone therapy. So that's what I hope to do today. So the goals of the talk are to review recent findings from the WHI and other randomized trials of hormone therapy, describe some of the clinical characteristics, that are important in risk stratification and deciding who's a good candidate for hormone therapy. And this includes age, time since menopause, underlying clinical risk factors, whether a woman has metabolic syndrome, whether she has dyslipidemia, high blood pressure, et cetera, some of the biomarkers that have been helpful in risk stratification. And all of these variables, how do they modify health outcomes on hormone therapy? And how can they be used in identifying women who are particularly good candidates for hormone therapy and those who should avoid hormone therapy? So I also want to go through some of the clinical decision-making algorithms that are available and address the role of recent research in improving clinical decision-making for hormonal therapy and some of the options that are available for non-hormonal therapy. Now, this perspective piece, it was circulated, it was published in New England Journal several years ago, and it was to make the case that women are receiving very fragmented care in terms of menopause. Most clinicians have decided just not to prescribe hormone therapy. It's too complicated. And many women are suffering because of that. They have severe, moderate to severe hot flashes, night sweats, often interrupting sleep, impairing quality of life. And they're having a lot of trouble finding clinicians to treat them. And I actually hear from a lot of these women. I try to help them to find clinicians in their area. The North American Menopause Society at menopause.org, they actually have a website where you can have patients search for, according to their zip code, for clinicians who have special training in menopause management. So I've often referred women in other parts of the country to that website. But this is a real issue. And about 75% of women in the perimenopause or the early menopause will have vasomotor symptoms, hot flashes, night sweats. About 20% of women will have what's classified as moderate to severe symptoms and would be candidates for menopausal hormone therapy. Not all women with hot flashes, night sweats need medication. Many can be treated with lifestyle modifications and avoiding triggers, or the symptoms are so mild that it isn't really worth going on hormone therapy. But about 20% will have significant symptoms that disrupt sleep and impair quality of life. And hormone therapy is the most effective treatment for vasomotor symptoms. Now, this slide just shows how menopausal therapy reduces the number of hot flashes in the trials that have been done. One finding to point out is that you always need a placebo group in these randomized trials of any treatment for hot flashes, vasomotor symptoms, because even in the placebo group shown in white, you're going to see a 30-40% reduction. But with menopausal estrogen therapy, this is conjugated equine estrogens plus medroxyprogesterone acetate, even with very low doses. The traditional dose is 0.625 milligrams of conjugated equine estrogens, what we tested in the Women's Health Initiative, and about 2.5 milligrams of medroxyprogesterone acetate, or MPA. This is not to recommend this regimen. We'll get into some of those formulation issues in a minute, but it's just to show whether you use the traditional dose or lower doses, even down to 0.3 milligrams of conjugated equine estrogens, you are going to see an 80 to 85% reduction in hot flashes, night sweats, very substantial reductions that are clearly separated from the effect seen in placebo. Now, some women are not candidates for hormone therapy. We'll talk about which ones in particular should avoid hormone therapy. And fortunately, over the last 10, 15 years, there are some non-hormonal treatments that are available. So we have the low dose paroxetine, which actually is the only FDA approved treatment, but there are many other forms of antidepressants. There's the SSRIs, the SNRIs, the serotonin and norepinephrine reuptake inhibitors such as venlafaxine, escitalopram. These are all at least moderately effective, 40, 50, 30 to 50% reduction compared to placebo. Not quite as effective as menopausal hormone therapy, but still can make enough of a difference that they are really worth trying in a woman who is not a candidate for estrogen therapy. Gabapentin is another category of treatments. These are the most common doses of the non-hormonals, and that also has been associated with about 40 to 50% reduction in vasomotor symptoms. So these are important to keep in mind as backups in women who are not candidates for menopausal hormone therapy. But generally, the societies of women's health, North American Menopause Society, Endocrine Society, American Association of Clinical Endocrinologists, many others do consider menopausal estrogen therapy or combination estrogen progesterone therapy as the first line of treatment. Now, I want to talk about why the effects of hormone therapy may actually differ in younger women, early menopausal women versus women more remote from menopause. And here are two cross sections of coronary arteries, one in early menopause and one in women in later menopause. And in the one on the right, this is in the context of established atherosclerosis. Now, on the left, in a woman who is very recently menopausal, she's likely to have healthy coronary arteries. Of course, she'll have some fatty streaks, but she is not likely to have complicated plaque. And her endothelium is likely to be very responsive to estrogen. What estrogen does is it increases nitric oxide synthesis, and that leads to vasodilation in a healthy blood vessel where the endothelium is normal, as in early menopause. It also has the effect of actually reducing inflammatory activation, leukocyte adhesion. Some of the lipid changes can decrease progression of atherosclerotic plaque. I'll show you some evidence for that as well. So it's an overall quite favorable effect of exogenous estrogen on the endothelium and the coronary artery in a woman in early menopause. Now, in sharp contrast, in a woman, let's say in her later 60s and 70s, who may have advanced plaques, estrogen has almost the opposite effect. First, the endothelium is not accessible to the estrogen. The receptors are underneath the fibrous cap. They're really not accessible. And estrogen does not have the effect of increasing nitric oxide synthesis or leading to vasodilation. In fact, there's some evidence it may lead to a paradoxical vasoconstriction in the setting of a stenotic blood vessel where there's already advanced plaque. Another issue, as you well know, is that you can have a stenotic blood vessel that may be particularly vulnerable to blockage from a clot, especially with oral estrogen, which increases coagulation factors, increases clotting. In that scenario, an older woman who has a stenotic blood vessel, she may be at high risk not only of a ruptured or eroded plaque due to some of the effects of estrogen on MMP, and she will not have the vasodilation, but she may actually have thromboocclusion of the blood vessel. So two directly opposite effects on the coronary arteries when estrogen is given in early menopause versus later menopause. So it's not too surprising that the results may end up differing by age and time since menopause. But for so many decades, we did not have randomized clinical trials. We had the observational studies, and the observational studies based on more than 40 fairly large studies, including, Nurses' Health Study, the summary relative risk for coronary disease in women who were using hormone therapy were about 40 to 50% lower than in women who never used hormone therapy. Very marked differences. And of course, some of this association may have been related to confounding that women who were being prescribed hormone therapy tended to be higher socioeconomic status, better access to healthcare, probably more health conscious, healthier lifestyle practices. But it's also the case that in the observational studies, many of the women seeking hormone therapy were seeking treatment for hot flashes, night sweats, and they were in early menopause. Compared to in the randomized trial, many of the women are at older ages. They don't have severe menopausal symptoms. So there's a very different clinical group in the observational studies and the randomized trials. But the observational studies actually did not really reveal that there were major differences by age group. And that may be because the women, even if they were in their 60s or 70s, had been taking hormone therapy since early menopause, and they were just continuing to take the hormone therapy, or their overall risk of coronary disease and general cardiovascular disease was so low due to other factors such as healthier lifestyle practices and a higher socioeconomic status. But these age differences, time since menopause differences, really did not become fully apparent until more recent analyses of randomized trials. Now, this slide just summarizes some of the differences between the Women's Health Initiative, we're going to talk about in some detail, where the average age at hormone therapy initiation was 63 years. The women were 50 to 79, versus the observational studies where the average age at HT initiation was 52 years. The time since menopause obviously would be quite different under that scenario, more than 12 years in the WHI and only 1 to 3 years in observational studies. And you may be wondering, well, why in the world did WHI test women with an average age of 63 years, the whole spectrum of ages 50 to 79 and 12 or more years since menopause on average? Well, there was a very strong rationale for that. At the time the WHI was started, it wasn't clear that there were differences by age or time since menopause. The purpose of the WHI was not to look at the efficacy of hormone therapy for treating hot flashes. It was to assess the balance of benefits and risks of hormone therapy for chronic disease outcomes, such as heart disease, stroke, cancer, all-cause mortality. And if you study women at the very beginning of menopause, you're going to need a study about 30 years long. So it was really important to have women who were covering the spectrum all the way into their 70s as well, and had this average age of 63 years. Now, in the late 1990s, early 2000s, some of the secondary prevention trials of hormone therapy began to emerge. Probably the best known is the Heart and Estrogen Progesterone Replacement Study, or HERS, that was published in 1998. And this was a study, again, of conjugated equine estrogen and MPA, looking at women with a history of cardiovascular disease. And it showed not only no benefit for reducing coronary events or other cardiovascular events, it actually showed a slight increased risk during year 1, which may be due to what I was showing you, the increased risk of plaque rupture, maybe of a thromboocclusive event in a stenotic blood vessel. These other randomized trials, I don't have time to go through them in detail, but it's not necessary because I can summarize in one sentence that not a single one of these secondary prevention trials showed a benefit of hormone therapy for clinical cardiovascular events in a secondary prevention setting. So when you take women who are already at high risk of cardiovascular disease, they're post-MI, or they have, let's say, documented atherosclerosis or prior stroke, any of these high-risk women, they do not do well with hormone therapy, and it really should not be prescribed in that scenario. And this is true whether it's oral estrogen or transdermal estrogen, whether it's which, regardless of the formulation of the progesterone, it is really not a favorable setting for initiating hormone therapy use. So this brings us to the 2 large-scale randomized trials in primary prevention, the parallel trials, estrogen plus progestin and estrogen alone trial in the Women's Health Initiative. Now, the design of this trial, again, it was women ages 50 to 79. I'm going to just get rid of this floating bar at the top. And women, it was divided up into whether or not women had prior hysterectomy. So over 10,000 women had prior hysterectomy, and they could be randomized to estrogen without a progestin versus placebo. And then the women who had an intact uterus, more than 16,000, they need to take a progestin to protect the uterus, and they were randomized to continuous combined conjugated equine estrogen plus MPA at 2.5 milligrams a day. Again, it was the traditional dose of 0.625 milligrams a day versus placebo. Now, the results of the WHI, the E+P trial first, are shown in this slide, on this slide. Now, clearly, this is a very unfavorable benefit-risk ratio. And this is why the hormone therapy E+P trial, which was slated to last 8 years, actually stopped 3.3 years early. There was an increased risk of coronary heart disease, stroke, pulmonary embolism, even breast cancer, though the breast cancer risk with E+P didn't emerge until about 4 years after a randomization. There were some outcomes on the benefit side. There was about 1/3 reduction in hip fracture and colorectal cancer. However, it was clear that the risks outweighed the benefits. And later, an ancillary study looking at dementia, limited to women 65 and older, also showed that there was an increased risk of cognitive decline and dementia, especially with E+P, a little less so with E alone, but the 2 trials pooled showed clearly that there was an increased risk in dementia. Now, the E+P trial findings in 2002 led to these 80% reduction in hormone therapy use. So when the estrogen alone trial results came out 2 years later, they actually received much less attention. But what was important about the E alone trial was that, and this can be used in women with hysterectomy, was that although the stroke risk was quite similar to that found with E+P, and the fracture reduction was similar to that for E+P, everything else was in the null category. So coronary disease was not increased, pulmonary embolism was only very borderline, breast cancer was actually almost significantly reduced and later became significantly reduced. So conjugated equine estrogen alone did not increase breast cancer over 7 years, 6.8 years, and with longer term follow-up, a significant reduction in breast cancer began to emerge. It's almost like the conjugated estrogen was acting akin to a selective estrogen receptor modulator. That's one of the theories, like tamoxifen or something like that. But it was actually leading to a reduction. And whether this would be found with estradiol, transdermal estradiol, there haven't been large enough trials to look at that question. But with CEE, there was, if anything, a favorable result for breast cancer. Colorectal cancer here was neutral. All-cause mortality in the global index, which is a combination of all of these endpoints, was neutral. Now, that's where everything stood for a long time, that there's a lot of concern about the risks of hormone therapy, especially estrogen plus progesterone, and many women were not taking hormone therapy. However, we were interested in the question about whether the results did differ by age and time since menopause. So we did a very detailed analysis that was published in JAMA in 2013. And I'm going to go through those results with you. First, I want to highlight that the absolute risk of various chronic disease outcomes and adverse events vary tremendously by a woman's age. And I think you all know that very well. So the first column is age 50 to 59, the middle column 60 to 69, on the right is 70 to 79. The upper half of the slide is the E plus P trial. The bottom half is the E alone trial. And what you can see is that whether you're looking at the active intervention or placebo, active is solid bars, placebo is the striped bars, you are going to have much higher absolute risk among women who are 70 to 79 or even 60 to 69 compared to women 50 to 59, who are generally the best candidates for hormone therapy in terms of having significant vasomotor symptoms. And for women 70 to 79, it's like 4 to 5 times the risk of having chronic disease endpoints. So even if the hazard ratios were identical, let's say younger women, older women, they all had a 30 or 40% increased risk of an endpoint, you would still be seeing many more extra cases of adverse events in older women than in younger women. But it turns out that even the hazard ratios and the relative risks differ by age group, especially for coronary outcomes, as might be expected by the endothelium differences, the cross-section slide I was showing you, and also for all-cause mortality. So this slide is from that JAMA paper when we looked at the 3 10-year age groups. Total MI is the most rigorously adjudicated CHD endpoint. And we saw for women, and this is estrogen alone. I'm going to start with estrogen alone because the differences were even clearer for estrogen alone than for E plus P. But with E alone, women 50 to 59, their hazard ratio with treatment compared to placebo was 0.55, really no reduction in age 60 to 69, and kind of trending toward an increased risk, though not significant, in the women in their 70s. For all-cause mortality, there was a similar trend of a signal for risk reduction, age 50 to 59, neutral 60 to 69, trending toward increase for 70 to 79. These p-values for trend by age group, increasing age group, were statistically significant, suggesting that age was an important factor in modifying the effects of hormone therapy for MI and for all-cause mortality. Now, for the estrogen plus progesterone trial, we actually didn't see clear signals by age group. However, the only group that had a statistically significant increase in MI with E plus P was the 70 to 79 year age group. However, when we looked at it by time since menopause, and we were interested in looking at time since menopause in addition to age, because many women, they may have been 55, 58, but they actually had gone through menopause in their mid 40s, and they were many, many years past menopause, which may be accounting for some of the up and down in the hazard ratios. When we looked at it by time since menopause, we saw no increase whatsoever for MI in those within a decade of menopause onset. A little bit of an increase for 10 to 19 years, but it was not a significant increase. It was a doubling in risk for those 20 or more years past menopause. And the p-value for trend was highly significant when it was looked at by time since menopause, but actually was not significant when looked at by age group in the E plus P trial among the women with intact uterus. Now, I want to show you some additional evidence for timing of menopause, the relationship between the timing of hormone therapy initiation and onset of menopause, and why the timing hypothesis is actually quite supported by the evidence and this critical window hypothesis. The one trial to date that was designed specifically to test the timing hypothesis was the early versus late intervention trial with estradiol, or the ELITE trial. And this was a trial done at USC. Howard Hodis was PI. This was 643 healthy, recently menopausal women. It was looking at women who are either within 6 years of the onset of menopause or 10, or some of them were 10 or more years past the onset of menopause. And so they were looked at separately according to whether it was early or late menopause. And the intervention was an oral 17-beta estradiol. So this was not conjugated estrogen. And the progestin was a micronized progesterone, actually a progestogen, not a synthetic progestin. And that was given as a vaginal progesterone gel 12 days of the month. And the outcomes, the primary outcome was the rate of change in the carotid intimamedial thickness. They also looked at CAC and CT angiography, but the carotid IMT was the main endpoint. And what they found was the top two graphs are showing the women who were more than 10 years since onset of menopause, when they were randomized to hormone therapy, placebo in black, and the estradiol group in green. Actually, this is not a significant difference. The results were very similar. Both had this similar progression in carotid IMT. The bottom two curves show the women who were less than 6 years since the onset of menopause. In the placebo group, you had a pretty substantial increase in carotid IMT, and this was markedly blunted by estradiol, a significant difference in terms of the rate of progression of atherosclerosis by carotid IMT, significant difference here. Also a significant interaction between early menopause and late menopause. So this provided quite strong evidence for the timing hypothesis. Now, just to be comprehensive, I do want to mention that the KEEPS trial, the Chronos Early Estrogen Prevention Study, which also looked at early menopause and looked at different types of estrogen, oral, transdermal, and change in carotid IMT, did not see any significant difference between the placebo group and the hormone therapy group in terms of progression of atherosclerosis. But this is being interpreted as this was a very low risk group that had very minimal change in the carotid IMT compared to the ELITE trial. Now, I've shown you the results for estrogen and E plus P for heart disease or myocardial infarction and all-cause mortality, but I do want to highlight that hazard ratios were actually quite similar by age group for stroke, venous thromboembolism, breast cancer, and other outcomes. But the key point is that there were much lower absolute risks in the younger compared to the older women. The women in early menopause versus later menopause, they tended to have better hazard ratios for coronary disease and all-cause mortality. But for some of these other outcomes, the hazard ratios were similar. However, when you're talking about lower absolute risks, you also have fewer adverse events occurring in those groups, in those patient groups. And just to highlight this point, and you have this in the New England Journal Perspective piece, if you look at a typical clinical scenario where a woman is being treated with hormone therapy for 5 years, let's say over a period of 5 years, even though symptoms do sometimes last more, on average about 7 years. Let's say she's being treated for 5 years, and you take 1,000 women who are in their 50s, at an age where they might be reasonably treated for their vasomotor symptoms. What you see is actually very, very few extra adverse events. Here it's CHD, stroke, DVT, breast cancer, colorectal cancer, all cancers, all fractures, all-cause mortality, diabetes, and and death. What you see is I'm sorry, it's blocking. But anyway, what you see is that the risks, you have to divide this by 5 to see the number of women per year. But even over 5 years, you're generally getting fewer than 5 extra cases per 1,000 women of having these events. And you also have a lot of cases that are being prevented. You have a lot of cases of fracture, all-cause mortality is prevented, diabetes is lower. With both E plus P and E alone. So you are seeing both benefits and risks, and overall, these absolute risks are quite low in the women who are 50 to 59. Now let's compare this to women at older age groups. So if you look at the E plus P trial and the E alone trial across these different age groups, and green is generally favorable findings, and the boxes plus signs are increased risk. What you see is that E plus P is associated with some extra cases. As I showed you, there were some increased, there were extra cases of stroke, even though very small, and increased risk of venous thrombosis with the oral estrogen. So you do get some cases, but much lower number of excess cases compared to the older women, 70 to 79. And for all-cause mortality, you actually get fewer deaths with both E plus P and E alone. And in the E alone trial, women with hysterectomy, it's just so favorable for women 50 to 59 and even 60 to 69. And the quite unfavorable results are seen in the women who are 70 to 79. Now, just to go over the mortality results in a little greater detail, we looked at, this is during the intervention phase, in the 50 to 59 year age group, we saw all-cause mortality was lower in both of the trials. In pooling the trials, it was actually 0.69, which was a significant P trend for age and a significant finding of a risk reduction. CVD mortality, even cancer mortality, other mortality were all on the side of lower risk with estrogen alone. Another finding that we published recently was looking at bilateral oophorectomy status and these very favorable results seen with estrogen alone in women with hysterectomy. About 40% of them also had bilateral oophorectomy. did the results differ according to oophorectomy status? And we published in Annals of Internal Medicine that, in fact, both groups looked favorable, whether they had a bilateral oophorectomy or ovarian conservation with the hysterectomy. However, it was particularly the women who had bilateral oophorectomy who seemed to benefit. And for all-cause mortality over the long-term follow-up, this was follow-up over 18 years, and there actually was a significant reduction of 0.68 or 32% reduction in all-cause mortality over 18 years among the women who had bilateral oophorectomy and were given estrogen alone. So this was a group that seemed to particularly benefit. And I'll show you in the next slide. This is a group with a conserved ovaries. Everything looked pretty neutral. All of this is clustering around in this forest plot. It's all clustering around neutral. Certainly, there was no evidence here of anything being significantly increased, but the greater benefit seemed to be in the women who had bilateral oophorectomy, particularly if they had early removal of the ovaries. This is just a summary slide that shows the results during the intervention phase. We've kind of gone through all of these results. And then the post-intervention phase, because we have follow-up for more than a decade after the trials ended. And what you can see here in the slide is for E plus P, there was the increased risk of breast cancer, stroke, PE. And this was true even in younger women, but just very small absolute increases in, very, very small numbers of excess cases. And the global index was really unfavorable across the board, but very close to null. And if this is offset in a woman who's in her early 50s and she's having severe symptoms and impaired sleep, disrupted sleep, impaired quality of life, these very small increases may be worth it for her with shared decision making, because she's still extremely unlikely to have a clinical event. For many of these events, it's less than 1 in 1,000 women receiving the treatment per year who are having one of these adverse events. For CEE, the risks were really limited to stroke and some very small increase in venous thrombosis. Breast cancer was reduced. Hip fracture was reduced in both cases. Colorectal cancer reduced with E plus P. Many of these cardiovascular risks dissipated after stopping hormone therapy. So during the post-intervention phase, many of the risks went away. Interestingly, the breast cancer, increased risk of breast cancer persisted at about a 30% increase in the E plus P trial, and a similar reduction, close to 20% or more reduction in breast cancer persisted with E alone. So just diametrically opposite results for breast cancer in the two trials. And we also found very interestingly that with this regimen of continuous combined estrogen plus medroxyprogesterone given in this dose continuously, there was a significant, more than 30% significant reduction in endometrial cancer. That emerged more clearly during the post-intervention phase. Why would we recommend transdermal, estrogen patch rather than oral estrogen in some patients? Not every patient needs to be on transdermal rather than oral, but some of the clinical scenarios where transdermal is seriously worth considering is, there's a less effect on clotting factors. There isn't the first pass liver metabolism and increasing clotting factors. You don't get the increase in the triglycerides. You don't get the increase in C-reactive protein, though this increase is of unclear clinical significance when it's just the without an increase in IL-6. It's just the C-reactive protein synthesis in the liver. And blood pressure is very slightly increased with oral estrogen. We don't have large-scale randomized trials of transdermal estrogen looking at clinical cardiovascular events, but we do know that in clinical trials of transdermal, less effect on clotting factors, triglycerides, CRP, and blood pressure. I'm going to come back to some scenarios where you would consider transdermal, but let's just talk about dose effects. What about lower doses versus the more traditional doses? I think pretty much across the board, we should avoid high doses. There is some evidence that with lower doses of conjugated estrogen, there may be less increase in blood pressure and less effect on blood pressure with low dose with transdermal estradiol, such as in the KEEPS trial. And we're also seeing that there is this increase in systolic blood pressure with the traditional. It's only a couple millimeters mercury, but still you want to avoid anything that increases blood pressure if you can, and if you can get away with a lower dose like 0.45 or using transdermal, that can avoid this increase. And with stroke, we've looked in the Nurses' Health Study, which is an observational study, at the relationship between dose and stroke risk, and seen that the lower dose of 0.3 milligrams was not associated with increased risk of stroke, whereas 0.625 milligrams was associated with a similar increase in stroke as found in WHI. And but the results are still somewhat inconsistent. In a Danish national registry, there really wasn't a clear association between risk of MI and estrogen dose. I want to briefly say something about bioidentical custom compounded hormone therapy. These are the hormones that you get from special pharmacies where they compound them. These are not FDA approved bioidentical hormones, of which there are many. Many bioidentical hormones are FDA approved, such as the estradiol, 7-beta estradiol, the micronized progesterone, and they're very much recommended as a choice for consideration. It's the compounded hormones where we have some concerns because they're not really monitored for consistency of dosing or for purity and lack of contamination. This has really burgeoned into a billion-dollar industry. It's very heavily promoted, the compounding hormone therapy industry. And the North American Menopause Society, many of the professional societies, as well as the National Academy of Medicine, really advise against these compounded hormones because women are not informed about the risks. They're not given the package insert, and they tend to be led to believe that these hormones are safer and more effective than the FDA approved hormones. And in fact, they've been tested for neither efficacy nor safety, and they may have many more risks. What about biomarkers? How do they help? Generally, it's the same pattern that I suggested. Women who are at higher risk of cardiovascular disease tend to do worse on hormone therapy than women at lower risk. If they're older, if they have more risk factors, they tend to do worse. If you start out with a woman has a healthy low LDL cholesterol, she tends to do better on hormone therapy than if she has a high LDL. If the ratio of LDL to HDL is low versus high, she's going to do better. And if she doesn't have metabolic syndrome, she'll do better than if she does have metabolic syndrome. This is especially true with the oral estrogen, estrogen plus progestin. I'm going to show you some decision-making algorithms where breast cancer is one of the factors. And I just want to comment, there are many risk scores that can be used for breast cancer. There's the 5-year National Cancer Institute, as well as the International Breast Cancer Intervention Study score. But generally, it's asking women about their family history of breast cancer and number of close relatives with breast cancer, and also whether they've had a breast biopsy with atypia. And so if women are generally not having those risk factors, they tend to be at relatively low risk of breast cancer in terms of the hormone therapy decision making. But of course, it's very reasonable to go through the, actually calculating a score for breast cancer, though I doubt that most clinicians do that and probably just base it on asking women about their family history and whether they know they've had a positive biopsy with atypia and some of those risk factors. This is one of the decision-making algorithms that we've recommended. We published this actually many years ago in Menopause and earlier in Harrison's textbook of medicine, where we had the hormone therapy and menopause chapter. What we recommend here is that hormone therapy use really should be limited to management of vasomotor symptoms and menopausal symptoms. For systemic hormone therapy, it would be used for moderate to severe hot flashes and night sweats, symptoms that are interfering with quality of life, disrupting sleep, affecting day-to-day activities. If a woman does not have those symptoms, but she has the vulvovaginal symptoms or genitourinary syndrome of menopause and vaginal dryness, pain with sexual activities, she could still be a candidate for low-dose vaginal estrogen and other treatments for that purpose. But we're focusing more on systemic hormone therapy in this talk. So really be looking for the women who have an indication for hormone therapy, systemic hormone therapy, such as moderate to severe hot flashes or night sweats. Again, this is probably about 20% of women in early menopause. And of course, look for contraindications and whether a woman is open to menopause, being treated with hormone therapy, because if she is very adamantly against hormone therapy, especially due to a family history of cancer or whatever, then you want to start to go down the road of the non-hormonal options, rather than continuing to push for, I would not recommend pushing if a woman is resistant to hormone therapy, but many women are very open to it. And if there are no contraindications, such as free of breast cancer, endometrial cancer, these clinical cardiovascular diagnoses, other contraindications, then the decision can be made largely on her underlying, the number of years since menopause onset and her underlying cardiovascular risk, together with a breast cancer risk score, or considering whether she's at excess risk of breast cancer. We generally recommend, and this is the vast majority of women who have the really bothersome moderate to severe hot flashes, they will fall into the category of being within 10 years of onset of menopause and having a quite low cardiovascular risk score. If you use the pooled cohort equation, the ASCVD risk score will usually be less than 5% in early menopause. So HT would be considered a very reasonable option. As you get to higher levels of the ASCVD risk score, up toward 10%, you may want to consider transdermal over oral. And where do you avoid hormone therapy? Once you get to more than 10 years since onset of menopause, generally avoid it unless this is the initiation of hormone therapy. A woman may have started in early menopause and want to continue past 10 years. And that's a different decision-making process. I'll get to that in a minute. If a woman has a high CVD risk, especially greater than 10%, this is quite uncommon among women in the first decade after menopause, but that would be a scenario of avoiding hormone therapy. And the conjugated estrogen basodoxifene, which has been linked to lower risk of breast cancer and in lower risk of osteoporosis, would also be an option instead of a progestogen. in a woman with an intact uterus. Then you have the issue of deciding about duration of use. And, continuing use should really be past 5 to 7 years, should really be limited to women who continue to have the symptoms, continue to have moderate to severe symptoms. They really want to continue. They're doing so well and they try stopping, but they get their symptoms right back, and their symptoms are disruptive to sleep and very bothersome to them. And just weighing their baseline risk of breast cancer, cardiovascular disease, and osteoporosis. There are no, really hard and fast guidelines. There's a lot of art to this and clinical judgment, and also shared decision making is so important in this decision-making process about whether to continue the longer term use or whether to stop. This is the algorithm in the paper I circulated. It's really very similar, just a simplified version of what I just went through for you. This is a paper we published in JAMA a few years ago on a clinical insight series on initiating menopausal hormone therapy. Again, are there vasomotor symptoms? Confirm that hot flashes or night sweats are adversely affecting sleep, daytime functioning, quality of life, assess risk factors, and overall, if there's a history of cardiovascular disease, deep vein thrombosis, pulmonary embolism, you probably do not want to start hormone therapy. And then some of the groups that do particularly well would be women below the age of 60 and menopause onset within 10 years and who don't have extra, special risk factors for breast cancer, cardiovascular disease. Women where you would avoid it would be those with high risk of breast cancer, cardiovascular disease, or they are past that window of, age 60 and 10 years since a menopause onset, and they also have at least average risk of breast cancer or cardiovascular disease, plus being in later menopause. And everyone else would be consider with caution, and particularly the woman's preference and shared decision-making are so important. When do you consider transdermal? We went through, some of the characteristics of transdermal versus oral. It's particularly helpful in the clinical setting of obesity and metabolic syndrome, where there's an increased risk of thrombosis, in the clinical setting of diabetes as well. High triglyceride, generally we recommend avoiding, but if it's only a moderate elevation in triglyceride, transdermal is very reasonable. Higher risk of thrombosis, especially if it was a provoked event of VTE. Now, an interesting group is women who have decreased libido and some reduction in sexual functioning. We recommend transdermal rather than oral because the oral estrogen increases sex hormone binding globulin and can decrease the free testosterone. And we did see in the KEEPS trial, I'll show you those results briefly, that the women on transdermal estradiol did better than those on oral conjugated estrogen in terms of sexual function. Women who have migraines, but without aura, may still be candidates for transdermal. We generally recommend avoiding hormone therapy in women who have migraines with aura, and also gallbladder or liver disease. Generally avoid hormone therapy if the gallbladder hasn't been removed, but transdermal may be an option better than oral in terms of gallbladder disease risk. This is just what we found in KEEPS in terms of effects on sexual function. We found that both the oral conjugated estrogen and the transdermal estradiol had benefits in terms of we found benefits in terms of vaginal lubrication, but overall, we found that sexual function and libido were more improved with the transdermal than with the oral conjugated estrogen. This was a female sexual function inventory score that included a number of domains of sexual function, and overall transdermal estradiol, but not the oral estrogen, led to improvement in the overall score and in overall sexual function, but both did improve lubrication. And so in that area, the two formulations were quite similar. But keep this in mind if a patient is complaining of low sexual function, that and if you're going to be starting hormone therapy, that transdermal may be a better option than oral. So in conclusion, hormone therapy, it continues to have an important clinical role in the management of menopausal symptoms. The current evidence, we're not recommending hormone therapy for prevention of cardiovascular disease or other chronic diseases. And you may ask, well, why is that? It may lower coronary disease, especially with estrogen alone. But there's also the flip side of the equation, that it might increase risk of stroke and venous thromboembolism, and with E+P breast cancer. So generally, it's not really a treatment for, as the WHI was designed to look at the balance of benefits of our chronic disease outcomes. I think we can say that it really shouldn't be used for the express purpose of preventing chronic diseases. But in early menopause, we have a lot of women with disruptive and bothersome menopausal symptoms and hot flashes, vasomotor symptoms. It's quite reasonable to use hormone therapy for that purpose. And the best candidates for hormone therapy used for that purpose are recently menopausal symptomatic women who are in generally good health. They have more likely to have the symptoms of menopause, and they have low absolute risks and greater of adverse events and greater quality of life benefits. It is helpful to use a risk stratification and a personalized approach to decision making, as I've gone through and is in the article I circulated. This is not a one size fits all decision making process. And we do need, in terms of gaps in knowledge, we do need additional studies of the different HT formulations, particularly transdermal, estradiol, and micronized progesterone, and more research on non-hormonal options, including benefits and risks. And I'd like to end by thanking so many people who have contributed to getting these answers, in particular, all of the participants in these research studies, the women nationwide who participated in the WHI and so many other menopause studies, hormone therapy studies. They have really given so much of their time and energy to help get these answers. And really, we owe them a very profound debt of gratitude. Also, all of the investigators and staff members nationwide and throughout the world who have worked on these research studies. And I thank you for your attention, and we'll be happy to answer any questions.
Dr. Manson, that was just a truly superb presentation. We're going to let you go tonight, but thank you again so much, and we'd love to bring you back for a version 2.0 sometime in the future.
Thanks so much, everyone.